Welcome to my scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel. Hello, this is Dr. Grande. Today's question asks if I can talk about the Shane Dawson video on Eugenia. She's a content creator that became kind of extremely thin during the time she was on YouTube and then kind of dropped out. And then we see this video with Shane Dawson kind of exploring the possibility of eating disorders. Now, as a mental health counselor, this was actually kind of a tough video to watch, and not because it was poor quality or anything like that. I thought it was fine in terms of editing and all that part. But the subject matter itself, I think, was challenging. I've treated many people with eating disorders, and we've seen, of course, good outcomes in terms of clinical practice, like I've seen good outcomes, and I've also seen some less than ideal outcomes. So again, this was kind of challenging. Now, Shane Dawson and Eugenia and Kati Morton was in this too. All these people, of course, are real people. So just an important note that I'm not diagnosing anybody, just speculating about what could be happening in a situation like this. So as I mentioned, we see this YouTube content creator, Eugenia. She was active on YouTube for quite a few years. She has a lot of subscribers, a lot of views, was very popular. And over time, she appeared to get quite a bit thinner, and I think you could argue to an alarming degree. And then, as I mentioned, kind of dropped out of sight. She said she was taking a break. And of course, this statement generated a lot of speculation. So then we move from that now to Shane Dawson's video, right? So that's kind of where it picks up on her return to YouTube after this break. So in Shane's video, he's really just interviewing her and maybe trying to bring some attention to eating disorders. And he had some help understanding these disorders from another content creator, Kati Morton, who also has a fairly large YouTube channel about mental health. So as I mentioned, this was a little challenging to watch, and when I first saw the comments coming through and the emails coming through, the request to do this video, the one I'm doing right here, on the Shane Dawson video, I think what first kind of hit me was a bit of worry, right? As a mental health counselor, we largely kind of sit on the sidelines in terms of like social media. So, even if you kind of factor in that I have a YouTube channel, it's extremely small compared to a channel like Shane Dawson's, and extremely small compared to a channel like Kati Morton's. So again, largely mental health counselors, like me, just sit on the sidelines and worry. We see these different topics come up, and we go to play these videos and we wonder, what's going to happen here? We know that these individuals have a tremendous reach. They reach a lot of people. And if they say something correct, that's great, because a lot of people heard something correct. And if they say something less than correct, well, that permeates through the population as well. So some time ago, we see that Shane Dawson did a series on Jake Paul. I think there were 8 videos. And we see that he also had Kati Morton help him with some of those videos. And both of them kind of stumbled a bit around the topic of antisocial personality disorder. I already covered this in prior videos. So again, when I see this video come out, and all those comments and emails, I was a bit nervous to watch it. But this video is actually quite a bit different than some of the more worrisome videos we saw from that whole Shane Dawson, Jake Paul series. So we see kind of early on in this video, Kati is giving advice to Shane about how to approach this interview that he has upcoming with Eugenia. And Kati indicates that she cannot diagnose Eugenia because Eugenia is not her client. She's not Kati's client. I think Kati used the word patient, but I would use the word client. But either way, she was exactly right in this statement. And I'm really glad that she mentioned that in this video. I actually think Kati got a lot right in this video. She seemed to be extremely sensitive to the language that could trigger somebody in recovery from an eating disorder, which I thought really came from a compassionate place. Now, of course, there is such a thing as being too careful, a point where you don't truly interact because you're so afraid to say something. But I can appreciate how Kati may have viewed her advice as erring on the side of caution. And I like the way she essentially said not to push, not to intrude, to let Eugenia tell her story at her own speed and to what extent she wanted. Again, I thought these were all good moves. Now, of course, we see a few technical inaccuracies here from Kati Morton and from Shane Dawson. And I think everyone who watches my channel knows that I have to point at least one of them out, right? It's the nature of being a scientist. For example, we see that Kati Morton indicates that Eugenia was running on adrenaline. That's how she had a lot of energy when she kind of appeared to be in a starvation mode. Well, adrenaline is involved in starvation, but bodies enter really into a series of metabolic modes. I'll put a link in the description for this video that looks at the process of starvation, and I'll also put links and the rest of the references that I used to make this video. So now moving to the interview itself, so this would be Shane Dawson and Eugenia. We see a tentative Shane Dawson showing a lot of respect for the seriousness of the topic. He asked her if anything was off limits, anything would be triggering, and she indicated that nothing was off limits. She said she had an eating disorder, right? So this is really, as far as I know, the first time that she said that, but she was non-specific. She really didn't assign a diagnosis or indicate a diagnosis, right? So, of course, an eating disorder would involve a diagnosis, but she didn't feel comfortable sharing that information. And I think to Shane's credit, he did not push for an answer. I think that was a very smart move, again, showing respect. Now, Shane did take a while to ask questions. Like, the questions weren't always clear. He kind of has a habit in his videos, I mean, I've only seen a few, but of the ones I've seen, where he asks questions with, like, it seems like 10 or 20 parts, right? He kind of just rambles on a bit and combines a lot of questions. Now, he's not a counselor, so we wouldn't expect him to be precise in the way he asks questions. But I think that what he was really doing here was out of an abundance of sensitivity, not because he really couldn't conceptualize his own question. He just wanted to be careful. At least that's the impression I was left with. So we learn a little bit about Eugenia's treatment experience in this video as well. She was inpatient as opposed to outpatient. She talked about that experience, and I think that was helpful. She talked about being a person first, so a person is separate from a disorder. That's excellent. And then we see Shane moves away from the topic of mental health and essentially says, what else do you like to do? Like putting mental health to the side. What do you enjoy doing? And I think that was really another good move. I just thought that brought balance and kind of perspective to the situation that she was in, not just focusing only on the mental disorder. So in this video, we don't see a lot of detail or a wealth of information necessarily, but under the circumstances, I think Shane handled this interview relatively well. So some questions I received specifically about this situation. Is it really possible to not realize how thin you are, right? Kind of specifically referring to the Eugenia situation, but I'll be talking about it, of course, in general terms. So the answer is yes. It would be possible to not realize how thin you are in a manner of speaking, and I'll talk a little bit more about that later on. Another question was it really just a little too early to have this discussion, this interview between Shane and Eugenia, because she didn't really share a ton of information? And my answer to this question would be maybe. But it is helpful to learn about what people go through regardless of the stage of recovery. And it did appear that Eugenia didn't answer questions she didn't want to answer. She didn't give more information than she wanted to give. So it did seem that she was able to set boundaries. So as long as you see somebody setting boundaries, and they're really saying something that they want to say, then it makes sense, I think, at some level to have that type of interview. In terms of all the stages, recovery can be a long road, and eating disorders are really nothing to be toyed with. So it's good if we have, again, a lot of information about these types of disorders. Which brings me to, what does the research say about eating disorders? So I want to issue a warning here because some of this is a bit disturbing, understandably so, but it is a bit disturbing. So there are several eating disorders. The section in the DSM that contains eating disorders is actually called feeding and eating disorders. We see quite a few, like avoidant restrictive food intake disorder. We don't see this one too much, but it's a real disorder. Anorexia nervosa, I think by far the most popular in terms of what people would recognize. Bulimia nervosa, also pretty well recognized, and binge eating disorder. Of course, we see a few other disorders in that section. I'm going to focus on anorexia nervosa because of its prevalence and dangerousness, not because I think necessarily that's what's going on in this situation. Again, there's no way for me to know about that or comment on that. So with anorexia, we see a few different symptoms. We see a restriction of energy intake relative to requirements, so not eating enough, right? We see an intense fear of gaining weight or becoming fat. And then we see, I think, a really important criterion: a disturbance in the way in which one's body or shape is experienced, undue influence of body weight or shape in terms of self-evaluation, or a persistent lack of recognition of the seriousness of the current low body weight. We also see that anorexia has two types. Now, the word type means something very specific when you're talking about the Diagnostic and Statistical Manual, the DSM. We see a restricting type here and a binge-eating, purging type. And what this means is that if somebody has anorexia, they have to have one of these types, because types are mutually exclusive and jointly exhaustive. So sometimes you'll hear people say, well, I've been diagnosed with anorexia nervosa. And I might say something like, well, what type? Oh, there's no type, just the general disorder. That's not a thing. There has to be a type. If somebody was diagnosed with anorexia and not given a type, maybe that was like an oversight by the clinician. But technically speaking, of course, as I said, there does have to be a type. Now, the binge-eating, purging type is often confused with the disorder bulimia. So that can get pretty confusing pretty quickly when we talk about eating disorders. Now, with anorexia, we also see kind of factors, moods, characteristics that tend to co-occur, that tend to occur along with anorexia, like depressed mood, social withdrawal, irritability, trouble sleeping, a diminished interest in sexual activity, obsessive-compulsive features, high levels of impulsivity, inflexible thinking, right? I think that one's fairly obvious, and a strong desire to control the environment. Now, in terms of the treatment of anorexia nervosa, we see that only 10% of people with the disorder will ever seek treatment. And the treatment can be quite expensive. If we're looking at like inpatient, for example, which sometimes, of course, insurance would cover or cover part of, we see that the average cost is $30,000 a month, right? So one could argue prohibitively expensive treatment. Now, here's the part I think is a little bit more disturbing that I referenced earlier with that warning. We look at anorexia and we look at the mortality risk, and it's a little bit shocking. And to understand mortality risk, we have to understand the construct of the standardized mortality rate, sometimes called the standardized mortality ratio. I'll refer to this as the SMR. SMR is calculated by dividing the observed number of deaths in any particular group by the expected number of deaths based on the age and gender in the population. So, for example, if 20 deaths are observed, but only 10 were expected, the SMR is equal to 2. In the population, the SMR would be expected to be 1. So the comparison SMR is always 1 if you're comparing pathology to the general population. So when we look at the SMR for anorexia, it's 10.5. 10.5. So it's extremely high. It's actually the highest risk, the highest SMR of any mental disorder in the DSM. 5 to 10% of people with this disorder will die in the first 10 years of having the disorder. 18 to 20% will die in the first 20 years. And some of this, of course, is from starvation and other complications related to not eating, and some is due to suicide. So for comparison, if we look at some other disorders that we know are somewhat dangerous to the person who has the disorder, we see bipolar disorder. The SMR is 2, right? So somebody's twice as likely to die in the same period as somebody in the general population. Schizophrenia, 2.5. Heavy smoking, which of course isn't necessarily a mental disorder, it's just something we know is dangerous, 2.5. Antisocial personality disorder. We know a disorder that is dangerous to the person who has it, 8.5. So even antisocial personality disorder has a lower SMR than anorexia. Anorexia has the highest mortality rate on average, but we also see even a higher SMR in specific situations. For example, a female with anorexia in the first year after presentation of the disorder, the SMR in this situation is 30. 30 times the expected, right? So 30 times the risk of somebody in the population. So the risk is not equally distributed across the duration of the disorder. So now moving back to that earlier question, is it really possible not to realize you're this thin? Of course, I answered it yes, in a sense. So there are a couple parts here, right? Really a couple questions that put together can answer this question. What do they see when they look in the mirror? Are they hallucinating? Somebody with this disorder, are they hallucinating? Are they not seeing how thin they are? Well, they actually see the same thing that everyone else sees. The challenge is not on what they see, it's on what they tend to focus on. They tend to focus on something very specific. This is really a type of perfectionism, which kind of makes sense because obsessive-compulsive disorder is highly comorbid with anorexia. I mentioned that before. So they see themselves as thin, but they may focus on something like the shape of their legs, or the way their shoulder looks, or how one cheek looks maybe different than the other cheek, like a lack of symmetry, and they won't be satisfied, right? So again, they appreciate that they're thin, but there's still something in their mind that's wrong with their body. So the second question, the second part of this that kind of answers that other question, is this a delusional disorder? No. Irrational thoughts with this disorder are intense, but not delusional. We could consider anorexia like an egosyntonic resistance to eating, right? So what this means is egosyntonic. This means that someone's thoughts are consistent with their behaviors. They're not alarmed by their behaviors. It makes sense to them that they're not eating. If something was ego-dystonic, the behavior would be distressing to the person. They wouldn't want to do it. And of course, we do see other disorders that have an ego-dystonic nature. So again, with ego-syntonic, they're doing something they believe they should be doing. So personality disorders are also considered to be ego-syntonic, yet they are not considered to be delusional either, right? So delusional, really, that's a pretty high bar. That's a pretty high standard. There are a lot of things that people believe that don't make sense that we don't call delusions. There's a lot of things that people miss about themselves that we wouldn't necessarily call delusional. Now, there is an overlap, though, between anorexia and delusions. We know that 20% of people with anorexia also have delusions. And this is actually a bit of a mystery. We see a lot of theories as to why this happens. I'm not going to go through all of them, but a couple of the popular theories would be that starvation leads to psychosis. I think that kind of makes sense. We know that is the case in at least some of these instances. And the second one is that the underlying cognitive distortions between psychosis and delusions, of course delusions would be a type of psychosis, we know that the underlying cognitive distortions are similar between psychosis and anorexia. So psychotic disorders are still distinct from anorexia, but again, this kind of explains why we see so many delusions, why we see so much psychosis associated with this disorder. So overall, kind of stepping back at this whole situation and with all this in mind, looking at the Shane Dawson interview, his part, and of course the part with Kati Morton, we have to be careful and supportive when discussing eating disorders. And I think Shane Dawson in this video, and I mentioned as well Kati Morton, did a reasonably good job at that. I would like to see this discussion continue, of course, not necessarily with Eugenia. Of course, that would be interesting if she wanted to do that. But just the discussion in general, I think, should continue. The discussion around eating disorders and kind of the stages of recovery and what each stage looks like, what it feels like, what somebody might expect. I think this is an important conversation. How can we be supportive to somebody with an eating disorder, including anorexia? Well, there are a few things that I would put out there. One would be to listen without judgment, right? That's, I think, very important, a really important component. We'd want to recognize the disorder is complex, recognize there is no easy fix. It's not a lack of willpower. It's not as simple as turning the disorder off. I'd say be willing to interact with somebody who has the disorder. That sounds kind of simple, but a lot of people are afraid to say anything. I mentioned this before. We can become so cautious that we don't even interact. We don't even build a relationship. And building a relationship is really a key part of being supportive. And the last thing I'll throw out there is to recommend counseling and remove barriers to counseling. Make sure that someone understands there's no shame in going to counseling. Normalize the experience. Going to counseling is normal. It's an expected activity. In some way of thinking, it's really routine. Somebody can go to counseling with no specific objective in mind, right? So it's not like somebody has to say, go to counseling so you can gain weight. Rather, you could just say, go to counseling so you have somebody to talk to, somebody on your side, somebody you can share your thoughts and feelings with in a safe environment. So there are other things, of course, that can be done to be supportive. Those are just some of my thoughts. I know whenever I bring up topics like this, like the whole idea of eating disorders and how to approach situations when somebody has an eating disorder, I know there are going to be a variety of opinions here, people who agree with me and disagree with me, and have other thoughts and examples from their own lives. Please put those opinions and thoughts in the comment section. They always generate a really interesting dialogue. As always, I hope you found this description of eating disorders and support to be interesting. Thanks for watching.